Today I will be presenting a case of glioblastoma multiforme with an atypical encephalitis-like presentation, focusing on the diagnostic challenge, radiographic progression, and surgical decision-making. This case is based on a published open access report and is presented for educational discussion only. Glioblastoma multiforme is a World Health Organization Grade 4 astrocytic tumor and remains the most aggressive primary brain malignancy in adults. It is characterized by infiltrative growth, rapid progression, and significant intratumoral heterogeneity. Although the classic radiographic appearance includes irregular peripheral enhancement with central necrosis and extensive vasogenic edema, early presentations may deviate from this pattern, which can complicate early diagnosis and delay definitive management. The patient is a 66-year-old woman who presented with acute left-sided hemiparesis and focal motor seizures. Given the acute neurological deficit and imaging findings, the initial differential included ischemic stroke as well as inflammatory or infectious etiologies. There were no imaging features that were clearly diagnostic of a high-grade neoplasm. On initial evaluation, a non-contrast CT of the head demonstrated a hypodense lesion in the right temporal lobe without hemorrhage or a clearly defined mass effect. Subsequent MRI demonstrated a poorly circumscribed lesion in the right temporal region that was hypointense on T1 weighted sequences and hyperintense on T2 and FLAIR imaging, with surrounding vasogenic edema. There was no well-defined ring enhancement or central necrosis on the initial study. Given the diffuse borders of the lesion and the absence of classic malignant features, the imaging raised concern for encephalitis rather than a primary brain tumor. This represents a well-recognized but important pitfall, as early glioblastoma can radiographically mimic inflammatory pathology. Despite initial management directed toward a presumed non-neoplastic process, the patient's neurological exam continued to worsen. Given this clinical progression, repeat MRI was obtained. Interval imaging demonstrated clear disease evolution, including the development of heterogeneous peripheral contrast enhancement, central necrosis, and increasing vasogenic edema. At this point, the radiographic findings were highly concerning for a high-grade glioma, and glioblastoma multiforme became the leading diagnosis. Given the patient's neurological deterioration and evidence of increasing intracranial pressure, surgical intervention was indicated. From a surgical planning standpoint, the lesion was located superficially within the right temporal lobe, involving the non-dominant hemisphere, making it amenable to resection. Given these factors, the decision was made to proceed with maximal safe resection rather than stereotactic biopsy. The chosen approach was an open microsurgical resection via a right temporal craniotomy, with the goals of obtaining tissue diagnosis, achieving cytoreduction, and providing decompression. This approach is consistent with current evidence demonstrating that in glioblastoma, greater extent of resection is associated with improved progression-free and overall survival when it can be achieved safely. In this case, an open temporal craniotomy provided optimal exposure for tumor debulking while minimizing risk to eloquent cortex. This case highlights several important teaching points relevant to neurosurgical practice. First, glioblastoma is a biologically aggressive and dynamic disease, and early imaging may not reflect its full malignant potential. Second, diagnostic anchoring can be problematic in cases with atypical radiographic features, particularly when the clinical course does not improve as expected. Third, serial imaging is critical in the evaluation of progressive focal neurological deficits. And finally, while advanced imaging is invaluable, histopathology remains the definitive diagnostic standard and guides subsequent management. In conclusion, this case illustrates how glioblastoma multiforme may initially present with features suggestive of an inflammatory or infectious process, resulting in diagnostic delay. For neurosurgeons, the key takeaway is the importance of maintaining diagnostic flexibility, correlating radiographic findings with clinical progression, and pursuing timely surgical intervention when malignant transformation becomes evident. Thank you.